on a Tuesday evening to come, or Monday evening to come and talk to us. I've followed your work closely for years and years, and as a postgrad, we've read so many of your papers. So I think everyone who's joined in tonight is aware of the research that you're doing. I didn't realize you were doing research into restorative dentistry as well and some peri-implantitis, which is fantastic. And I'm really looking forward to seeing how you've put your lecture together on irrigation made easy. And at the end, we'll try and open it up for questions. So we will unmute everybody later on, and we will try and make it interactive at the very end of the lecture. So I don't think you need any more introduction. And whenever you're ready, you can start.
Thanks, Daniel. You hear me?
Yes, yeah, I can hear you.
Very nice. So I'm happy that you knew me already as a postgraduate student. So that ages me quite a bit. Anyway,
It's meant as a compliment.
Yeah, thanks. But anyway, I'm gonna, present this little lecture, and I think as there was, as I heard, some disturbances with the last lecture. We'll
security features today.
Oh, super. So I'll try to make this kind of a little bit quick, and then we can have a nice discussion about it. Maybe it's the best if we just, you write down your questions, or we have the questions towards the end of the lecture. This lecture is really a little bit one of my standard lecture on irrigation, so to speak, but I do have a conflict of interest in this lecture because one, I'm going to mention or talk about in a little bit more detail one product that I developed through my research, but I'm going to get into that towards a little bit the end of the lecture. And that product is a chelator or a decalcifying agent. And that is all because I work at university. This is all secured by contracts through our technology transfer. So there's nothing wrong with that. I really earn my bread with working, being a professor at the University of Zurich. But also, I think maybe something that is different in Zurich compared to other universities, that we have faculty practice for professors and senior lecturers. So we can work on private patients, and so I'm an endodontist and I work in my own practice, which is inside university, but Switzerland is a fee-for-service environment, so I think a lot about how to do the best treatment and how to save time, make more money, just to put it bluntly, and the time that I have with the patient. And so this lecture is a little bit about that. So I'm not telling you that the way you do it or the way other people do it is wrong, because I think there can be many ways to do endo. There can be many, there's a lot of like fashion trends, like, narrow instrumentation and things like that. I don't think that's all that important really, but it's a matter of preference. But the things I'm talking about is more the basics, just to understand the basics, and then everybody can do with this whatever they want. But I also try to explain why I'm doing the research and developing the products that I try to develop. And that is really based on some very, very simple biological principles. And one of those principles is really, when we do a root canal, I mean, I guess most in this forum are endodontists.
There's a lot of endodontists, endodontists and dentists with special interest in endo.
Oh, okay, super. And so I think what some, at least endodontists, tend to forget is the pulp. So we don't get to see many vital cases, but we get the referrals from the GPs who do the vital treatment or the emergency treatment. And one problem I see with that is that, the tooth necrotizes from the crown into the pulp. So that's the nature of the disease. So pulpitis, apical periodontitis, two sides of the same coin, really. Question is, where do you stop with your intervention? Now, of course, with the pulpitis, you could do a pulpotomy. Not many people do it, but you could technically do it. But then as the bacteria go down in the root canal, you get necrotized tissue, but you still have a lot of remaining vital tissue. And you can see that in a cone beam CT. You get the lesion, you get bone resorption before the infection reaches the apical area. So you have still a lot of vital tissue down there. So we have a tendency to maybe overtreat also in terms of the length, but that's not the topic of today's lecture. The topic of today's lecture is really irrigation, debridement, cleaning the root canal. And what I see more and more now these days in my cases is that GPs, they use reciprocating files and they don't irrigate much. And it has nothing really to do with the reciprocating files. I have nothing against the reciprocating files. It's just I don't like the way people use them because they save a lot of time. And now in the old days, they used to put calcium hydroxide. They did hand instrumentation. The calcium hydroxide dissolves the tissue. But when you do a treatment like that, and this is a typical case of a vital treatment done by a GP in Switzerland, and he or she left a lot of formerly vital tissue in this fin. And what happens with that, you cut it off, it becomes necrotic, it becomes filled with biofilm, and then you get the apical lesion. Like that happens within about 3-4 months. So depending on the case, but I think it's a problem and people don't address this problem properly. I always used to think that, vital cases are easier to treat than non-vital cases. That may be true for traditional endodontics, but not for the modern endodontics, where people just use a reciprocating file, stick it down the canal, and think it's done. So much for that. So of course, then once the infection reaches the apex, it becomes a biofilm-related situation where you have biofilm also in ramifications in the isthmus, and you have this mixed anaerobic biofilm, and you have the host defense. And that, this inflammation can be very painful. It can be acute. It can go along with the swelling, or it can be primarily chronic, so the patient doesn't even notice it. But the problem here, of course, is once we want to heal the apical lesion, you have to get rid of most of the biofilm. And how we can do that is the topic of this lecture. I think to understand how we should do it, we should first understand what a biofilm is. And I think a biofilm is a general term, and it's misunderstood and misused also in endodontics, because a biofilm, according to Costerton's definition, is bacteria in an aqueous environment adhering to a surface. And so this is the way bacteria survive in nature. When you have bacteria in a water glass, they will form a layer on the glass. So the majority of the bacteria will adhere. They will not be suspended. The reason for that is in nature, you always have a flow when there's water. And so bacteria survive by adhesion. Now in the root canal, you don't have, once the root canal is necrotic, you don't have a lot of flow of fluids. So biofilm in the root canal is not necessarily biofilm that is, for instance, dental plaque, where you always have saliva flow. So I think this term is a little bit abused, misused, but still you have a matrix, and that matrix is not proteins, or is not only proteins, is actually mostly glycoproteins or sugar bonds. Okay, so, and that also something, the matrix of the biofilm, not something that is very well investigated in endodontic research. Of course, the first guys who investigated that was Nair and Luder with a transmission electron microscope in Switzerland. It's published in the Swiss Dental Journal. I'm the editor of the Swiss Dental Journal. Now, these days, we don't get so many good articles anymore, unfortunately, since I'm the editor. But in the old days, we had some good guys like Ram Nair. And actually, that's a very interesting study, and it was also published then again in a little bit different form in the Journal of Endodontics, but the nice publication is in the Swiss Dental Journal, where they describe 31 cases of painful apical periodontitis. Teeth were extracted, Rikuchi style, okay, and then they did, they looked inside with a transmission electron microscope, and they found these FB, free bacteria, And HB is German for haftende Bakterien, means attached bacteria. So they described biofilm first time. Other interesting thing, we found a lot of spirochetes in these cases, in these painful cases, and those can never be cultured, but they're there in the acute cases, in the painful cases. So that was another interesting side note. But they were basically the first ones to really show this kind of biological concept of a biofilm in root canal. Now, the question is how to clean it out, okay? And that I have to open a little sidetrack. Depends a lot on the case. I think it's a major mistake also, again, that people do when they think about the time they spend with a patient. Not all teeth are equal, because the root canals, they form, okay, they're formed or are left out during the root development. So it's the biology of the whole concept that the root canal follows the form of the root. Okay, so when you have a round root, have a round canal. That's number one. Number two, an adult tooth doesn't have a lot of open dentinal tubules. A kid's tooth is hard to disinfect because the bacteria go into the tubules. An adult tooth has sclerotic dentin in the apical third, and that's the third that matters clinically. So in a tooth like that, in an adult, in a maxillary first premolar, you know, your irrigant or disinfectant doesn't really play a role because your round instrument can clean mechanically, and you just irrigate. You can use water. I'm not saying you should, but technically you could, and still get away with murder. I think where it becomes difficult, even in single-rooted teeth, is when you have oval canals, like, you know, in these examples. Of course, your round files never fit. When you have large lateral canals, this is a case published by Ricucci, where I don't know, maybe most of you know this case. They did an apical surgery on this front tooth. And it was a biofilm in a huge lateral canal. That was enough. That was enough. The main canal was properly filled. The lateral large canal, which is not very typical for a tooth like that, but still was enough of a biological challenge for the tooth to be symptomatic. So they had to be, there was a swelling, and so they had to do the apical surgery on this one. Another case by my friend Michael Arnold. He's a keen endodontist in Germany, and he's really, really very exact, very good clinician. And even he missed a ramification here in this first molar. And Ricucci, again, then they did the apical surgery. Ricucci did his super nice histology, and again, biofilm in a space that could not be cleaned. So I think it's all about understanding a little bit the history of the case and the anatomy of the tooth to be treated. I think this is just the biological basis. Now I'm going to talk about the chemistry. Okay, and the chemistry is pretty clear. We can use chemicals these days still that historically were used to clean wounds in World War I, and that is hypochlorite. So I think hypochlorite these days would never go through any of the notified bodies anymore, so there could never be a new product containing something as aggressive. But for us, it's very, very helpful that we can use it, because if you could not use hypochlorite, our whole treatment concept would have to be different. We would have to treat in 2 visits with calcium hydroxide, because calcium hydroxide has essentially the same effects. It dissolves tissue, it dissolves biofilm, it dissolves organic stuff. Okay, but I'm going to just talk a little bit about some main features of hypochlorite that are necessary or important. Some people, especially in South America, also in Germany, they like to use chlorhexidine. I don't know why. Chlorhexidine is a disinfectant. You may use it as a final irrigant if you like. But just to show you here, this is a model filled with gelatin. This is a model of a isthmus. This is to study the removal of soft tissue, because gelatin is a soft tissue surrogate that is used in studies. And so you can see, I first here introduce my irrigant. Can you see that?
Yeah, we can see it.
I'm a little bit shaky because I'm a socially integrated alcoholic. So Sorry for that, but I always do these little movies on my microscope, freehand. So a lot of street credibility. So here I use an Irrigation tip. And you see, this is the chlorhexidine. And you see what happens here is the gelatin discolors a little bit. I don't know whether you see it, but really nothing much happens, okay? So now I irrigate with a hypochlorite. It's just 1%. I use 1%. You can use 3%. You shouldn't use 5% if you're not stupid. But this is a hypochlorite. And you just see immediately how the gelatin dissolves. And you can also see the lateral action. I get back to that. The lateral action of the ultrasonic tip, which I like, is a controlled action. And it works in conjunction with hypochlorite. So there's a synergistic action of hypochlorite and ultrasound or pulse laser. Okay, so cavitation and hypochlorite, they work together. It's like alcohol and cigarettes. So when it comes to the hypochlorite, people have some weird ideas, especially in Scandinavia. And I think there's a lot of traditionalists in dentistry. So, if somebody in Scandinavia said something 1953, it's the rule. It's never questioned. Okay. So there was this idea that, or actually Dakin himself had this idea that pH should be adjusted of the hypochlorite. That happens to be not true, because the cleaning action of the hypochlorite is much better at extremely low or extremely high pH. And naturally, hypochlorite has a pH of 12. So we leave it the way we buy it in its more stable form. Or if anything, we can add some alkali and we make the proteolytic action much stronger. So the cleanser is the hypochlorite. So you just leave your hypochlorite the way it is. It's more stable. And also, the more concentrated it is, the less stable it is. It's another conundrum, but that many people don't know. But if you buy it like at 3%, it's stable for a couple of months. If you buy it at 1%, it's stable for half a year or more. So if you buy it at 15%, it will be 10% relatively soon. But also the alkalization of the hypochlorite and the fact that it works better when it's alkaline opens this door. What I learned from my teacher, Gunnar Hasselgren, always mix a calcium hydroxide powder. Still some companies produce that, some dental companies like Produit Dentaire, Lege Artis in Germany. I don't know about England, but calcium hydroxide, the powder, you can buy it also from a dental supplier, and then you can mix it with your hypochlorite solution. Why do I do that? The hypochlorite will be gone in about 30 minutes. We measured that. So then it will be over, but you buy some extra chair time when you treat in 2 visits, because as I said initially, I don't want to spend too much time with my patient. So I want to keep the chair time as short as possible. This is why I do it. I buy some chair time.
When you finished your instrumentation, how long do you irrigate then before you medicate?
It depends. If I do it 2 visits, I don't irrigate much. I just medicate it. And then I irrigate more in the 2nd visit.
Right.
Yeah. Well, I'm talking more about irrigation. It's just a little sidetrack towards the calcium hydroxide. I know it's out of fashion. I still think it's a very, very valuable clinically, especially with these chronic pain patients that I'd sometimes leave the calcium hydroxide in there for half a year or longer. Tell the patient, you call me when your tooth doesn't hurt anymore because you have a chronic pain problem. So with the calcium hydroxide suspension, I know it stays put. No need for changing it or anything like that in an adult tooth. So
what's your experience in those cases? Because all of those kind of cases were...
With the chronic pain?
Yeah.
We have a pain center here. I do studies on it. It's usually the patients are not easy to handle. Some are very thankful, but you need the key of it. The key to it is communication. I think there's a lot of things you think, this or that guy's a good endodontist because they can clean around the curve of the canal. I think the good endodontist is the one who knows his cases, and the chronic pain cases, they're difficult to handle, but you need, the key to them is good communication with the patient, not making them expect that the pain will go away because you treated the tooth. You should never consider pain as something, an outcome or reduction of pain as an outcome that you could achieve as a surgeon or microsurgeon or mini surgeon or however you want to call yourself. Okay. Pain has many times nothing to do with inflammation or infection. And I think you have to just know these cases and then communicate. Say, okay, like this is the way I'm doing it. I know it's not good to have this tooth filled. You don't like it to be filled when it's still painful. So you tell me when I fill it.
Yeah. No, I
If
think
it never hurts, if it never stops hurting, go to speak to your doctor, and then you need to go on a special pain medication that I can't prescribe because I'm not a physician. So
it's very easy to get sucked in those cases where you end up doing treatment and then you do surgery and then you do an extraction and still the same pain.
Oh yeah, that's just what called, the new term for it is persistent PIDAP, persistent idiopathic dentoalveolar pain. I think it's quite a good name because dentoalveolar, you pull the tooth, the alveolar hurts. So it's a central aspect to that type of pain. We did a recent study on a lot of cases that my friend in Germany, Frank Zehnder, treated because he gets all these referrals from the frustrated endodontist. Quite interesting. I mean, I can send you the paper, or it's available online. I can send it to anybody who, you just send me an email at the end. If you have any questions, I can send you guys papers or whatever you are interested in. But anyway, back to the disinfection. I think, again, the matrix, what we did in this study, we had like a biofilm model on a hydroxylapatite disc. Doesn't really matter much. It's a 3-species anaerobic biofilm, but what you see here in green is the matrix. What you see in red is the bacteria, the living cells. So this is not a live dead stain, even though it's red and green, but this is a different type of stain. This stain goes for the matrix, which is the slimy stuff that holds the bacteria together, and the bacteria. And so as you can see, the hypochlorite not only kills the bacteria, it dissolves the bacteria. It dissolves the matrix. Okay, and I have never published these results, but you can do the same thing with calcium hydroxide, which actually the secret of these alkaline chemicals that we use in dentistry is one of their main secrets is really they dissolve the organic dirt that is in the tooth. Okay, nothing else does that. Another thing with the hypochlorite, it's not called bleach for no reason. If you compare, this is a model we developed recently on, human dentin, and we stain it with blood for a couple of weeks, and then we destain it with different medications or solutions. So hypochlorite actually at the same concentration or same molarity as hydrogen peroxide. This is hydrogen peroxide at the high pH and at the low pH. And this is hypochlorite, and this is the control, just treated with saline. So this is treated for 60 minutes with 5% hypochlorite in this case, just to show the difference, is massive. Mm-hmm. So it bleaches better than the peroxide. Now, of course, you can ask, why is there no walking bleach technique with hypochlorite instead of hydrogen peroxide? The reason is you would destroy the tooth. So if you have a highly, or even calcium hypochlorite powder or highly concentrated hypochlorite solution, it destroys also the collagen in the dentin and makes the tooth more brittle. But it bleaches, and when you use it in a tooth, for instance, a trauma tooth, you see that you already get a little bit of discoloration just by using hypochlorite as an irrigant. Another thing is people forget about is disinfection of the dentin wound that we used to do in the old days. Tubulicide, or in the old adhesives, there was glutaraldehyde in the Gluma, in the Syntac Classic. Now there is no disinfectants anymore. So we did this randomized trial with my friend Vasudev Palal in Manipal in India. So they treat a lot of deep caries, and so in Switzerland we would never get the number of patients, but these are like 3 good dentists treating these cases. 96 cases with deep caries and not much pain. Caries close to the pulp, posterior tooth, and then a randomized trial. So it was excavated to expose the pulp. So it was just complete excavation, not selective excavation. And then the bleeding was just stopped with saline, 30 seconds, and then was randomized 30 seconds saline versus 2.5% hypochlorite, then MTA, then glass ionomer cement, then restoration. Interestingly, you would think the hypochlorite would cause more pain immediately after the treatment. I'm not showing you this, but this result, but apparently from the third day onward, there was less pain with the hypochlorite. And then this graph here is the painful, the emergency patients that came back. Out of those 48, 13 from the saline group came back in their first 3 months with a painful pulpitis. 1 in the hypochlorite group came back. It's a huge difference, 2.5% hypochlorite. Why is that? Because the hypochlorite not only dissolves the bacteria, it dissolves a little bit these micro abscesses under the caries. So it's a chemical form of partial pulpotomy, because the hypochlorite is selective on the necrotic tissue. So it doesn't affect the vital tissue as much as the necrotic tissue. So by cleaning the wound, the dentin wound, or also the pulp wound, you can improve your outcome quite considerably. But I'm just showing the slide to show you the magic of hypochlorite, in clinical dentistry.
Was it 30 seconds exposure?
30 seconds.
Wow.
And another thing that I like as a clinician, the champagne test by yours truly, Buchanan. I think he coined that term before he got disturbed in your webinar. But it's just, you see that, I'm not sure whether the resolution is good enough, but you see when it's still, you agitate, you activate your irrigant, and then you put new irrigant, and there's still a lot of bubbles coming up, it's not clean. So this is a test. What is it? It's oxygen and carbon dioxide from the organic stuff that is still in the canals. So I love hypochlorite. The question is it enough? Of course, no. We all want to kind of get rid of the smear layer. We want to, I think smear layer is not all that interesting, but of course, no filling material binds the smear layer. The other thing is there is some accumulated debris in the isthmus areas and the ramifications. So that was Frank Paquet and myself who came up with this concept, because we were looking at our micro CT scans, especially, Frank was looking at his micro CT scans, and we discussed it, and it's like, we should superimpose these before after, and we should look at the voxels that disappear. What is it? Is it dentin that gets accumulated? Okay, so we want to use something to get rid of that, but also I think something that people also don't think about too much is conditioning of the canal wall, because I know we have a thing called adhesive dentistry, we have restorative dentistry. All we think about is how to condition the dentin in the root canal. We didn't think so much about it. I think it's a mistake. So what did people try to do about that? I think an old idea is really to have a gel, which is a cobble wax usually with EDTA. During the instrumentation. Why is that not a good idea? First of all, the EDTA is trapped in the cobble wax. Second of all, it increases the torsional load on the instrument, because your dentin cuttings cannot float out. So it's much better. We did lots of study on that, also with Ove Peters. Much better to have a liquid in the canal when you instrument, an aqueous liquid. So the other idea was to then use EDTA in the end that has also a disinfectant. So once we instrumented with the hypochlorite, use EDTA with cetramide, EDTA-C. That is an old idea from the 50s. And then some other ideas is to use citric acid with the doxycycline. I think it's not a very good idea. I don't think it's available in Europe. Not sure about England. England is not in Europe anymore, so ciao. No, we're not in Europe either. We are in Europe, but we're not in the EU. So in Switzerland, so we are brothers in. So anyway, The other issue when you use citric acid or EDTA is, first issue is, I haven't mentioned it, these chemicals are highly non-compatible with hypochlorite. So you need to then, add them in the end, once you're done with your hypochlorite, and then again come with your hypochlorite. That's possible. Your hypochlorite will always get rid of the protein, the collagen that is exposed by these strong acids or strong chelators. As you can see here, this is the surface of a root canal wall after 3 minutes of EDTA. You see how the dental tubules erode. And what's more important for the filling aspect is not the tubules, doesn't matter. It's really the exposure of collagen, because collagen contains a lot of water. And most fillings don't really like that. They don't like to bind to the collagen. This is also why the old adhesives, they had this degradation of this hybrid layer. The newer adhesives got Scotch bond and everything like that, that contain a specific monomer called 10-MDP. They bind directly to the hard tissue phase, to the calcium phosphate. So they like a deproteinized clean area. This is also why the new adhesives really like hypochlorite. The old school guys, they think you should never clean dentin with hypochlorite because it messes up your adhesion. The fact of the matter is the opposite is true. Exact opposite is true. And I think one researcher also now jumped on this, and one very good one is Josette, my friend, Gamieri, who's in Birmingham. She does some excellent work on this about, really protocols. Where's the protocols? There's no protocols. Why is there no protocols? Because one company produces a sealer, one company produces the files, and then one company like Dentsply, they buy everything, or they buy the small companies, but they don't, put the things together the right way. So they say, okay, this is our sealer. This is how you condition the dentin. Okay, thank you very much. So it is important, because depending on which sealer you're using, which filling technique you're using, you need different conditioning steps for the dentin. Now, apart from the smear layer, you want to get rid of the smear layer anyway. But with the traditional protocols, some sealers like a final irrigation with hypochlorite, most of them actually, where other sealers like AH+, they like the EDTA to the surface, the collagen to be exposed. So you need EDTA in the end. So, but I'm going to get into that in a second. If you look at this is just adhesion of sealers to dentin in a push-up bond strength. So it's purely filled with sealer, no gutta-perca. So there's only one interface. Okay, when you look, and instead of EDTA here, we took HEDP, which is a chemical I'm just going to get into in a second. But this decalcifies a little bit, doesn't do a strong decalcification, but it decalcifies the surface. And the hypochlorite deproteinizes the surface. So if you just deproteinize with your protocol, so you just use simple hypochlorite, 2.5%, 5%, and you take BioRoot as a sealer, it adheres quite a bit. You do the same thing with AH+, it doesn't really adhere at all. You decalcify, you just decalcify, you don't use any hypochlorite, but you just use a chelator. Your BioRoot doesn't really adhere at all. Your AH+ adheres like hell. And this, I'm not talking about statistically significant differences. I'm talking about fold factor differences. Those are huge differences. So this again shows, and in older studies with Prasanna and Nilakanthan, we showed that the adhesion, for instance, of AH+ is directly linked to how much you can seal a root canal system. So, so these values are not completely unimportant, I don't think. So, yeah, sorry.
How difficult it is for us to get canals fully dry. How when there's like fins in them, like paper points aren't going to suck all the fluid out of canals if we're using like resin cements and stuff as well. And
that's the other point. That's the other point. Yeah. Sorry.
Like, and these studies are done in ideal scenarios, and clinically we can't come anywhere near to matching them. And if you're getting very poor kind of bonds in an ideal situation. In reality, it's many times worse again.
That is true. And that's why you need a simple protocol. And also, I'm going to show you some recent results on drying the canal, because also that's something that people believe strongly in. They believe in strongly, but I don't think it's that important, especially not with the bioceramic sealers, with the new calcium silicate-based sealers. Actually, they like a wet environment. But anyway, whoever wants to read, I wrote this a narrative review on that. It is in this Quintessence article. What do sealers and other materials actually bind to? Most of them bind to calcium phosphate. Most of them bind to the hard tissue phase, not the collagen phase in the dentin. Okay, so so that brings me to this to end up the chemistry chapter. It brings me to why were we looking for a different chelator? We wanted to look for something a little bit less aggressive. We wanted to look for something that is compatible with hypochlorite. So we did like a whole cascade of experiments. I'm not going to get into those, but if you want to, you can read this article. It's actually a long time ago now, almost 18 years ago, we wrote this article. And we found that HEDP was actually compatible with hypochlorite in the short term. And you could maintain all the hypochlorite features by mixing it with HEDP. This is actually also something that is used in the dishwashing industry and many other, in soaps. So HEDP or HEBP, as we called it in the beginning, because HEBP is the German, and there's a lot of chemical industry in Germany, but this is a German abbreviation from, it's a bisphosphonate. It's an old type of bisphosphonate, so it's not one that has an impact on bone healing. Same as anhydronic acid. So it's used in all kinds of situations. But what we did really then is to develop a product that is based on this chemistry and actually contains this medical grade powder. And so there's different types of HEDP, but this one is the one that is compatible with the hypochlorite the most. And what it really does is it's a powder that you can mix with your hypochlorite solution directly. And so mix it for 1 minute, or my assistant mixes it for 1 minute, and then I use that for irrigation and nothing else. So, and what is the clinical advantage of doing that? I think there's many advantages, and whoever wants to try it should try it, because it maintains all the features I was just talking about of the hypochlorite. But once, for instance, you fill your access cavity with a hypochlorite and dual-rinse mixture, this combined solution, everything becomes more shiny and clear because it has this combined deproteinizing and chelating effect. So you see some GPs, I teach a lot of classes for GPs, and in Switzerland, a lot of people use this product because it's a small Swiss company that produces it. They say, like, I see the canals now better with my loops even. The other thing, once you instrument a little bit over the apex, or you have a vital case, or you have a perforation, once you use EDTA, your bleeding sometimes doesn't stop because EDTA is an anticoagulant. HEDP also is also a chelator, but because it's mixed with a hypochlorite, you will never get bleeding. To me, this is a huge clinical advantage. And once you start to do retreatments, of course, with retreatments also, because it has a decalcifying effect, you get a little bit, the filling materials, you get them better off the canal wall. This is all subtle, but for people who are pros, who do nothing else than endo, to me, the difference is striking. But okay, I developed it, I'm biased, but the other thing, for those who are not pros, you can concentrate on your physics, on your instrumentation, on your agitation of the irrigant, and you don't have to focus on which solution to use and when to use it. We did lots of studies, and I can send you the studies on it. A randomized clinical trial. We did cytotoxicity, genotoxic analysis of the combination, because in the long run, if you use it after 5 hours, your hypochlorite will be reduced. So it generates it alters the HEDP, but the altered HEDP is not toxic. So, and your hypochlorite gets lost over time, but once you use it fresh, it's fine. And this is what, for instance, this guy here did. Giardino, they did some guys from Brazil. They had like infected dentinal walls and single-rooted human teeth, and they used the traditional protocol, hypochlorite, and then EDTA, and they combined it to the shorter protocol with the combined solution. And the shorter protocol had a better disinfection. Now, this is statistically different, but it's not clinically meaningful. I'm not saying you can do everything with EDTA and hypochlorite. The question is just sometimes clinically a little bit difficult to judge when to use what and for how long. So, I think the simple protocol has advantage. Also, simple protocol is even sometimes actually better than the combined or the alternating protocol, because what it does, it exposes the collagen fibrils in the dentin, but it doesn't totally denude them. And so many adhesive materials like this kind of thing, this kind of situation. So it renders your it renders your substrate, so to speak, clean, so you don't have a smear layer, but also you don't have aggressively altered collagen, dentinal wall with exposed collagen.
Do you use this as well then for deep caries removal for if there's like
no, then I use pure hypochlorite
for that?
Yes, pure hypochlorite, but you could use it also, but I don't think there would be a difference that you could actually measure, because the exposure time's too short. But once you use it during the whole root canal treatment, I think this chemical conditioning becomes an issue, and especially in the root canal itself. But I'm going to show you, I think there's even more important aspect, and it has to do with the application and the technique. And I'm going to get into that now in the last chapter of this lecture. But we introduced this in the student course 2019, and the students they don't really know what they're doing. They just do what we tell them. They always still use lateral compaction, but they always had the problem of blocking themselves out. And that problem, is reduced now. And also they feel more lateral anatomy than they used to. Again, it's my biased opinion, but I'm a teacher. I've been a teacher for 20 years, students. And I think this is just something that it may sound like unimportant, but it's actually one logical step if you think about the whole treatment. So this is the chemical aspect, and what I use in clinics is really, I use hypochlorite as the irrigation liquid. I always want to have a liquid in the canal when I instrument. I use the powder of the calcium hydroxide when I do a 2-visit. And I use the combined solution, which is a clear hypochlorite solution, and mix the Durin's powder into the hypochlorite. As simple as that.
Yep.
So I don't know, is there a question here already that we want to discuss? Because I've let another 10-15 minutes on activation of the fluids.
Yeah. There's one question. The mix EDTA and citric acid.
Yes.
So makes it clean and proper before wet obturation. Why would you mix EDTA and citric acid?
I know you wouldn't want to do that, because EDTA actually precipitates at the low pH. EDTA needs to have a pH of 8. Above that, at the solution, below that pH, the EDTA salt will precipitate. So you can't do that. So you can either use 10% citric acid if you don't want to use HEDP, or you don't have it in your country. Use citric acid, or use 17% EDTA or 10% citric acid, but then you need to think about the protocol according to your filling concept. So I would still use hypochlorite during the instrumentation. You can sometimes then in between take some EDTA and then again hypochlorite to get a little bit, while you instrument already, get a little bit rid of the debris. But it makes everything a little bit more complicated anyway. But I think when you're thinking about delivery and activation, there's different concepts. I don't want to go into the details of that, but it's just some very basic things that dentists seem to not know about. what I try to call high school chemistry, or no, this is actually a bit more advanced physics, but calcium hydroxide is not very soluble in water. So it has a depot effect. So the powder stays put and you get an equilibrium. So you have your canal walls, you have small opening at the apex, but that doesn't matter in this whole context. So once you put calcium hydroxide in an adult tooth, there's going to be hydroxyl ion release for a while, and then it's an equilibrium, and nothing happens. Nothing happens. You just leave it in there forever. You could fill your teeth like that. Nobody does it anymore, but technically you could leave it in there until the apical lesion healed, like Trunstad used to do. It's not clinically practical, but I'm just saying it's theoretically possible. And then the other thing that people don't understand is agitation and activation is not the same. Eddy or some sonic tool agitates the hypochlorite. So it's good for the GPs because they always instrument short. It propels the irrigant down the main canal, but it has no cavitation effect whatsoever, no sonochemical effect like a pulsed laser does or like a ultrasonic tip does. Okay, so first I'm going to show you this little movie on how I apply the calcium hydroxide. I use a small lentil spiral, usually the red one. It's a size 25 if I'm not mistaken. Always a rubber stopper, and then a little trick for those who don't do so much endo. When you have a lower molar, always instrument the lingual canal first, visual root, because the buccal goes into the lingual, and this is where the files break. And you realize that once you put your calcium hydroxide and it comes up the other canal, you filled a little bit the isthmus, and you get an idea that your canals might join. I mean, of course, you can also put two files to figure that out, but I'm just saying, start with the lingual canal. Use a small lentil spiral, a thin one, and use a relatively thin mixture of calcium hydroxide and hypochlorite. Because why? Because for the hydroxyl ions to flow, you need liquid. So it doesn't make sense to dry the canal and put the calcium hydroxide as dry as possible. So now I'm showing you some little household stuff because I think endo is a lot like cooking and cleaning. And this is just a little video I did with my daughter. I hope that the sound is not on, but this is like, my daughter's a vegan, so this is some yucky vegan food. It's like a biofilm, okay? It's like a biofilm. So you irrigate this biofilm that adheres to the pan, or, and you irrigate, okay, not much. You add the right chemical. Let's say in this case it's soap. You could also add hypochlorite. You irrigate, and I think a lot of, especially in Germany, I don't know why they do that, but some people irrigate like idiots. They use like 30 mil of irrigant per canal. It's really nothing. A root canal has 3 microliters, not microliters, no, microliters. I'm sorry, yeah, not milliliters, 3 microliters of volume. So that's 10 to the minus 6. Okay,
Right.
It's nothing. So you don't need 30 mil or 20 mil of irrigation. You simply don't need it. What you need is the irrigant inside, the right chemistry inside. You need to have it, let it sit there for a while, okay? And then you need a mechanical tool to clean it off. And now I'm not saying, I also use ultrasonic activation of the irrigant and stuff like that. But I don't think it's very clinically necessary in many cases, unless you really have an isthmus you want to clean and you cannot reach. But the cleaning of the main canal, which contains the main biofilm, is clinically by far the most important aspect. So I think instrumentation, proper instrumentation of the main canals, irrigation of the main canals, And having the disinfectant in the main canal while you instrument is totally under-researched and underestimated. But if you look at your cases, I mean, this is what they call in Germany the bathtub technique. Not many, even when you watch videos on YouTube or on Facebook, many people tend to forget that you can clean a canal much easier by instrumenting through your irrigant. And that works especially well with the dual rinse hypochlorite, but also works with the hypochlorite alone. And this is also why you need to build up your tooth and then instrument, have an access as a reservoir. You don't need any stupid glide or anything like that. It's counterproductive. Sorry for this movie. This is now where it instruments. But you see when you work with a microscope, once you start doing that, if you haven't done it before, you see what floats up and gets dissolved in this reservoir. So this is really something, if you don't take anything home from this lecture, try it at home. I mean, it's a massive difference. I did lots of studies on accumulated debris, and one thing I never published, but I came to notice, is the main aspect of what influences the amount of debris in the isthmus is not the irrigants you're using, it's who's treating the tooth. Some people are they push the instruments like idiots. You know, they don't irrigate enough, or they don't work through the irrigant. So that makes a huge difference. So the other thing that I think makes a huge clinical difference to me is also a game changer. It looks like something simple. It is simple. I'm not an early adopter, so I was reluctant to use this. I tend to bend always the tip in the beginning until I realized you can bend it up here to engage better in the canal. And then the other issue, you need to attach a rubber stopper. So I always do that, attach a rubber stopper. So I have my length control. It's a game changer. For those who don't use this, I mean, I have no stock in this company, although it's a nice little Swiss company, Produit Dentaire. They also produce it for Dentsply, so it's you can get it from all kinds of sources. But I think this cannula is a game changer. So again, when you use a bathtub technique with this cannula, this is a retreatment, typical retreatment case. This is dual rinse, hypochlorite. This is just 1% hypochlorite that I'm using because I work at university, so we have to order the same stuff for the students. So, but you see already how much stuff washes up just by the fact that once you reach your working length and you can get down with your cannula and you don't have any back pressure, so you need to, anyway, and that's a given in the retreatment cases, but there has to be some backflow. And then I love these files from another Swiss company, FKG, XP Shapers. They're pure cleaning files. They don't really give you a nice shape to fill, so I don't use them to shape. I use for the retreatment the shaper. I use for the initial treatment the finisher. I never use both. They're too expensive, and I'm a poor guy working at university. But those files, in conjunction with the cannula, in conjunction with the right chemistry, made me do lots and lots of cases, including retreatment cases, in a single visit.
Absolutely.
And so this to me is, those are all incremental steps, but it made me a better clinician over the years. This is just to show you, this is the finisher of the XP finisher. Again, I have no stock in this company whatsoever, but see a calcification here. This is a printed tooth. You see the finisher, how it cleans away at the wall. And this is what I like so much about it. This is an oval canal. So you think about biofilm attached to this wall. Think about how this cleans like nothing else. Not even an SAF. SAF will be relaunched. And that also cleans the walls really nicely. It's a really great idea. But this also then engages in some lateral ramifications, which I think is just clinically very, very useful. Now I show you a little video on why I like ultrasound. Again, this is a model. Same I showed you before. This is gelatin. This is a simulated isthmus. And this is a simulated apical lesion at the apex. And when you use such an Irrisafe tip, which I use when I have an isthmus, you see how it's laterally targeted action. This is now 2.5% hypochlorite before it was 1, so this cleans a little bit more effectively. And it only over irrigates because I'm stupid enough to put the file tip over the apex, okay? But if you do the same thing in an open system, and I learned that the hard way from our residents in the clinic, they love to use sonic activation to clean around the curve. So eddy, there's nothing wrong with eddy. It's just that many cases with apical lesions, you have, when you go to full length, you have an open apex situation. Sorry for my shaky hand. But now I come in with the eddy, and you see what happens. It shoots the hypochlorite out of the apex. And it doesn't clean laterally much. Again, that depends on the situation. Eddy can be a great tool in the right hands. I also think eddy is very good for those people who block themselves out, who don't irrigate enough. So that's the majority of GPs. For them, eddy is good because they have a blocked apex anyway, so nothing can happen. Yeah. But as long as you have an open system and you keep things clean, eddy can be dangerous. And I saw it. I saw a couple of cases in our clinic, you know, with severe postoperative pain because of over irrigation. So yes, it needs to be. I'm not against it. I think it's a great tool. It just needs to be applied a little bit with caution. And actually, that's a nice study from our friends in Basel, another Swiss university, Thomas Connard, Roland Weiger. So those are some good endodontists. And they measured the pressure of different irrigant devices and activation agitation devices like laser. Laser creates a negative pressure, creates pulses, but in the apex creates negative pressure. Self-adjusting file, ultrasonic, activated irrigation. Nothing really created a lot of pressure except for eddy and rinse endo. Rinse endo is kind of a pulsed irrigation device. I think it's not even on the market anymore. I think it was produced by Kerr, and Weiger used to love it, but you know, lots of dentists complain about uncontrollable bleeding after using it because of over irrigation. So I think controllability of your concept is an issue here. So this is my irrigation for dummies, and it's just the way I do it, okay? I'm not saying you have to do it that way. I'm just saying this is the way I figured it out for myself. So I do the axis, and I use Müller burrs or Mounts burrs to visualize the canals. I use a short cannula, cheap short cannula, for the access cavity metal. I love the austenite SX files, my favorite rotary instrument. And now they have it in Martensite. Doesn't make any sense. Of course, now with the new Pro Taper again, they change. I told many years ago, I told guys from the dental industry, you need to change the nickel titanium phases throughout your files, you know.
Yeah, of course. You need coronally and soft.
Exactly. There we go. So then I like to use the old school path files. That's a matter of preference. I like to shape with Pro Taper. I like to shape. I'm an old school guy. Okay. That doesn't really matter. You use whatever you like. But a long cannula and these kind of anatomic files, as I like to call them, XP Shaper or XP Finisher. Again, this is a little bit not true because I use the Shaper for retreatments. I use the Finisher for initial treatments. I don't use both. And then I use ultrasound to activate the irrigant. But the thing is, I use approximately 10 to 20 mil per case. I asked my dental assistant the other day again, how much irrigant do I use? I use 10 to 20. very rarely do I use more than 20 mils, because the difference is really I instrument through the irrigant. That makes you become more frugal with your irrigant. Okay. People complain, especially in Germany, where people are very cheap and they have social security dentistry. Cost is about, I think, €2.50 per capsule, depending on how many you have, or €3. They sometimes still order the hypochlorite from the pharmacy in Germany. They sometimes can still do that, but the new MDR will not be possible anymore. So pharmacies won't produce it anymore. All the products become more expensive, but also more controlled. So you're not technically supposed to use chemicals you just buy in the supermarket anymore, in dentistry. So, and now I'm sorry. Yeah.
Okay, so do you get your nurse to do the mixture for you at the start of the treatment? And
yes, when I put the rubber dam, I mean, she prepares the rubber dam and the clamp. Yeah. I put the rubber dam. I always put kind of a cotton roll, rubber dam protection. And while I'm doing that, she's mixing it.
And how much hypochlorite does she mix with one capsule?
10 mil, one capsule.
One capsule.
You need 1 to 2 capsules per treatment. Depending on how you irrigate. Of course, if you're like convinced, and that's the thing, as soon as you come, to me as a university guy, this is interesting. When you come to something like that, you realize how hard-headed clinicians are. I mean, they're very stuck on their principles and their protocols because they work, but they can't buy the concept that it could also work in a different way and actually even could be much easier and better, and one other thing, and it's usually because I lecture also a lot in Germany. Germany has a lot of intelligent guys, a lot of hard-headed people, and they like to argue about things. So one thing is the question about alcohol or saline. So when you submit a manuscript to a journal and you treat an extracted tooth, as is mostly done in these types of studies, you always need to use saline in the end. So all the papers, all the in vitro papers you read, they always use saline to wash out the chemicals. Or some people strongly believe in ethanol to get the canals dry before they fill. And actually, we tried that with this protocol that is good for AH+, which is the hypochlorite HEDP mixture, and then final irrigant with EDTA to really expose the collagen, because AH+ likes that. Or we use the bioceramic sealer, which is just the mixture during the treatment, after the treatment, nothing else. Actually, also works for this, but just for the sake of the argument, we use EDTA here. We didn't use EDTA here. And then we compared direct drying with the paper points to getting rid of the chemical remnants with saline, or extra drying with ethanol. No difference in leakage whatsoever. No difference in adhering to the dental wall, like the bond strength to the wall. So it's not necessary. It's really not necessary. I mean, you can do it if you like. You can use chlorhexidine as a final irrigant to wash out the other chemicals, or you can use saline as a final irrigant. There's nothing wrong with it. Question is, do you have to do it? I never did it. Most people never do it if they're honest, but all the research you read, it's done like that. So it is a huge, dissonance. So this is not the sharpest images, but this is the protocol I came up with my friend Silvio Lotanti, who's a graphic design dentist who missed his profession like I did. The guy is very good at graphics. So we came up with this just simple concept to show to people how to use this Duorid stuff. It's really, you mix it, then you have your access cavity filled with it, so it reveals the canals. You do a step down, you start instrumenting through the irrigant, and then once you start taking your length measurement, you have your path, you have your glide path. Of course, you don't want to have an irrigant in the axis for better measurement, especially when you have an amalgam. That should be clear to anybody. And then again, you fill it and you do your shaping and your activation. And once your champagne test becomes negative, your canal system is clean. What I like about this concept is a single visit concept. It's very controllable. Now, as soon as you have calcium hydroxide in there, the second visit, you spend a lot of time getting rid of the calcium hydroxide. You lose a lot of chair time. it's okay. I still do it, but I do it less and less.
It's very hard to get all the calcium hydroxide out of the canal.
Yes, you don't get it out actually. But as soon as you use a bioceramic sealer, what happens when the bioceramic sealer sets? It liberates calcium hydroxide. So there should be no concern.
But if you use another sealer, if you use
if you use another sealer, it becomes a little bit of an issue. But I don't think what happens is you fill your lateral canals, and there's a lot of endodontists who treat X-rays, not patients, and they love the lateral canals they filled, of course. So then, once you use calcium hydroxide, it fills your lateral canals. They don't show up when you fill. So this is the real reason why people use 5% hypochlorite. They don't care about the tooth or anything like that. They want to have a nice X-ray, so they get the cases referred. It's fine, but it's wrong. It's biologically wrong. So I don't mind whether I have calcium hydroxide in my lateral canals or my apical delta. Never get it out again. So what? Still the best root filling material there ever was. I mean, and I think the new calcium silicate sealers, especially the one that is mixed with water, which happens to be the BioRoot, is the only one that has an aqueous phase that actually sets. I like quite a bit. So again, summarize my lecture. Hypochlorite is the key agent. New devices is nice to have. They save chair time. You have to think about how much you can charge for your treatment, whether you want to invest in these things. You can do old school dentistry and be highly successful. Depends on how much you get, money you get for the time that you spend. Also, conditioning of the dentin is important to think about in conjunction with the sealer that you're using. That's it.
Absolutely. No,
so
absolutely.
If you have questions, very happy to have a little discussion.
There's lots of questions that have come up there, but I think as kind of a lot of the people in this group are endodontists, so I think because you're doing endo day in, day out, you've got big advantages over general dentists who just like to have a very simple protocol. So I
yes.
think once you're doing endo every day, it's kind of a lot easier to try new things and adapt, and to try new file systems, to try new irrigation systems, to try all the kind of new toys that come out. Because if you're doing endo all the time, it makes such a big difference to your job if you can kind of find the right tools to make things more efficient and effective as well. But also for your patients, if you can make things faster and without compromising on any of the actual endodontic outcomes you're trying to achieve, it's so much better as well.
Yes, but the problem a little bit with this is that endodontists sometimes don't like things to be too simple. And the main market for the industry, I mean, is the GPs. So a lot of I think the good, in a way, for instance, the SAF, the Redent guys, they focus on the GPs, for instance, and they want to make them clean the teeth better. I think an endodontist, a well-trained endodontist, can probably use pretty much what they like and get a good outcome and play around with things. But still, I think it does make sense to think about these issues, because I think the future is in advanced instrumentation and cleaning tools. And I think the chemical issue is pretty much solved. It's hypochlorite. Use the hypochlorite, and the HEDP just combines nicely with it, so it makes it easier. So I like to use it. But the future is really about improving the mechanics of the chemomechanical cleaning. And I tend to believe more in these new file systems than in laser or any other advanced tools that just, activate the irrigant. That's fine. But it's so much more effective to anybody who ever did anything in the household, or has any practical sense. It's so much more effective to really chemomechanically clean a surface.
Yeah. I think it's like everything. It's trying to get the balance right. So you're trying to maintain tooth structure in the right places.
Yes.
Get the activation, get it all kind of done, and also though not blindly following protocols where in a specific circumstance it doesn't make sense. So it's just trying to get people to think, and we're trained so mechanically, but actually it's like every single case you're actually trying to need to engage your brain and think, what am I trying to do in this case? and then work your way through it.
Yeah. It's like fly fishing. It's like fly fishing.
Can I go through some of the questions?
Yeah.
So the first one here that I can see, it may not be in order, but from Panos, thank you for your question. So thank you for fantastic points, Prof. Zehnder. Questions about drying the canals if you're using a bioceramic sealer. So Prof mentioned the canals shouldn't be fully dry, if I understood correctly. Could you clarify this recommendation?
Yeah, it's like that. Have you ever thought about why your bioceramic sealer doesn't harden in the syringe?
Yeah.
Why could that be? Because it's in the glycol basis, matrix. So glycol is just a matrix material, like for this. So once you introduce it in the tooth, the glycol sucks up some water that is around. And the bioceramic sealers is a misnomer. They are hydraulic calcium silicate materials. So hydraulic means they set on the water. MTA is the first, actually cavet. For those who know the cavet, calcium sulfate, gypsum, it's hydraulic. So it needs water to set. So this is why the cavet is a very nice material, and then the MTA. And now the bioceramic sealers, they need the water. Question is, where does the water come from? Of course, we all know these old studies by Papa and Messer and how wet is a root canal. There's always some liquid in the dental tubules. The question is how much. This is an under-investigated question. So this is why I like to use the only bioceramic sealer that does have a liquid phase, which is the BioRoot RCS. Everything else, like Total Fill and so on and so forth, is fine, but then you need to add some water before you fill, and you don't know how much. So there's no protocol for that.
Yeah. So is that water or saline, or does it matter?
Water is actually better for MTA.
Right.
It doesn't matter much, but technically it's water. But no, as soon as you put it in the root canal, there's some salts there and stuff. So, but just to answer this question, these sealers that come in a single syringe, they don't predictably set in the root canal. Take my word for it. I did not, because they sell really well in Switzerland, did a lot of those retreatments, and sometimes it just, nothing. It hasn't set.
So I mean, when I was doing surgery, that's why I changed from lots of the different sealers, because I used to see the initial sealers I was using when we were doing the surgicals later. It wasn't setting. So we spent a lot of time trying to test all the different ones to find ones that did set and did work.
Yeah.
I think it's something, but the big problem is that so much of the research is dominated by the big companies. And it's like, all the products need to be tested out in the research rather than just the big ones. Yeah,
that's also, this type of research is really not interesting, and it doesn't get you any grant money or anything like that. So people at universities, they need to do cancer research or something important. But dentistry, revolves around these questions. And I think whole adhesive dentistry evolved around extracted teeth and mastication devices. And, now adhesive dentistry works pretty well. Like 20 years ago, 30 years ago, when I started as a clinical dentistry, it wasn't all that great. You can take, I think also these endodontic journals, sometimes they go a little bit too much into the direction of, cell biology research and stuff like that. So, but it has really nothing to do with what is done in clinics, which is a pity, because I think not even these very basic questions are really addressed. And companies bring out products without protocols. I think that's a disgrace. Really. I mean, I'm against it. I mean, I'm against, I said, I like the FKG files, but they buy their sealer, the Total Fill, of course, from Canada. Okay, it's the same as a BC. So it's the exact same product, just a different packaging. But does it have a liquid phase? No. Can you predictably use it? Maybe. You have to figure out how to wet your canal before you fill it.
Yeah, no, absolutely.
And then there's the other issue. Gutta-perca is hydrophobic. Sealers are water-based. That's another problem. So there's lots of problems with these things, Sealing a canal still works best with epoxy resin and gutta percha. There's nothing better than that. But because I treat so many chronic pain patients, and when I do an overfill, I like the BioRoot because I can say, okay, this material was actually developed to be implanted in bone, so there's no issue with an overfill.
Look at the constituents of resin. It just doesn't. It's not a nice material to have.
No, it's not. It's not that you don't want to have it in your sinus, or something like that. So, and I follow some legal cases here in Switzerland because I'm sometimes called as an expert. And usually it's chronic pain patients in combination with an overfill, and then end up suing the dentist or the endodontist. So, better you not use a material that is.
Right. Next question here is, thanks for a brilliant lecture. Can I ask, when you achieve zero reading and you have your hypochlorite reservoir, how often do you, can I ask, when you achieve your zero reading, I think he's asking that, can you achieve a steady zero reading with your hypo reservoir in place, or do you need to?
No, I think if I may go back I can't go back in my lecture. This is my email address for those who want to, but I'm going to put it up again. This is actually why Silvio, my friend, made this. Actually, I gave this to a couple of endodontists and friends. For the reading, this has to be empty because there is some creeping currents when there's some metal, and many times you do a root canal retreatment through a crown or something like that. So you don't want to really have it needs to be a little bit dry here, so you can take just dry it with a little bit of air, but not directly blown into the canal, but from the side. And you dry it here, but in the canals you can still have your irrigant, and that actually improves or simplifies your reading. Also, there is a clinical folklore or a myth that hypochlorite will mess up your reading of your length measuring device. It doesn't.
Yeah, no, that's fine. No, absolutely. But I think some people do make that mistake though of having the tooth full of liquid, and then
no, then at that point you shouldn't do it. You should do it all the time, before and after, but not during the measurement. So I also teach that. I think that's something else that the industry does wrong. Again, because they focus on the GPs, they have the length measurement implemented in the motor, so it continuously measures. It doesn't make any sense for length control, because proper length control is the core of good endo. So you measure initially and then before you fill twice, not more than that. And I think continuous measurement is not good. It's done by the GPs who work without rubber dam and stuff. So I always tell, when I teach courses to GPs, which we do quite a bit, to not do that, and then just turn it off if they have the feature in their machine.
Fine. And so let's say we have a large lesion with totally, let's say, biofilm the whole way down. Do we really know how long it takes for the hypochlorite to break it down clinically? Kind of back to you. Can we use that?
We can have an idea about it, but we don't really know it. We don't really know it. We have an indirect way of assessing it by activating the when you activate and lots of bubbles come up, you see that. That means it's still a considerable amount of organic stuff down there. But once that stops, technically it should be clean enough to be filled. But that's, again, of course, a clinical concept and depends a lot on the case. But to me, it's kind of the best measurement we can get, because we're working in a complex environment. And again, not each tooth is similarly effectively cleaned. So to me, this kind of is another point that I really like, and it's an underrated aspect of hypochlorite, is really that you can do the champagne test with it.
Yeah. It's but will the champagne test be as good when there's just, let's say, when there's no pulp tissue, it's just like biofilm?
Yes, biofilm. It works. I mean, anything that it reacts with will create the bubbles. Right. And it doesn't really necessarily react much with the hard tissue wall. So
yeah. So if you just place hypochlorite on, let's say, dentine discs, you're not getting much bubbles.
No. But of course, if you expose dentin to 5% hypochlorite, even for an hour, it starts cracking, because it starts to attack the collagen in the dentin wall. And again, this is something that endodontists don't pay attention to. Endodontists, that I think that a problem also is with the specialization in dentistry, that the endo guys sometimes don't think about the restorative too much, and about that the tooth should actually still be used as a chewing unit. That shouldn't be forgotten, So, yeah, 3% is enough. Thank you.
Okay. And then how often do you replenish your irrigant between each file?
I just irrigate between the file to refreshen it. So I use 0.5 mil about. It's another thing. Once you use these Irriflex or these long irrigant tips, you tend to use less irrigant because your irrigant is more effective. It actually cleans from the tip up.
Yeah.
But you have to make sure that you get some form of a backflow. I think this modern tendency of not opening canals at all makes them difficult to be irrigated, and this I think it's can also backfire in terms of the cleaning effect. So you need to find a compromise, a Swiss compromise, as always.
Yeah.
I'm not for opening the canals like an idiot, but I'm also against not instrumenting. I see some cases on Facebook, but even by well-known endodontists, and I look at these cases like, really? Are you kidding me? This is how you treated this tooth? This is like, but this is a matter, maybe also a matter of taste. So we should check each other's recalls and also look at the types of cases we're treating.
Recall, isn't it? It's all about the recall.
Yes.
I think, okay, so there's a question here, one fill sets well. So one fill is a sealer I personally use. I mean, I used to use total fill as well. The reason I changed from that was because I was having issues with setting of the material.
Yeah, and what is one fill? I don't know that.
I can send you some samples of one fill as well. So it's a calcium silicate cement as well. But when that has, let's say that comes in a putty and a sealer, but the putty actually has an initial set in like 3 or 4 minutes. So it sets a lot quicker than some of the others. And it's like, so when I go back into, let's say if I fill 3 canals, there's one canal that I haven't filled, I'll go in and I'll check on the other canals to make sure that it's set. I've done a lot of surgery where it's like, or where we've filled canals initially and we end up doing surgery later on, we're able to check on the set on those. So that's a personal experience. I don't have like a whole research done on that, but from personal experience, and it's worked well for me.
But it's a putty, so it's only one material.
Putty, and there's a sealer as well.
Yeah, but you don't have to mix it. That's my question.
No, you don't.
Because for a predictable setting, you need to actually mix it with a aqueous phase. But then it maybe has a different carrier material, so it sucks more water. So that's why maybe it works better or it sets quicker. Or it can have calcium chloride in it. Calcium chloride, triggers the quicker reaction in these MTA type or calcium silicate materials. But anyway, I don't know that material, but I'm also not saying these materials necessarily is proven to not work. They could work. All I'm criticizing is they're just putting those out in the market and there's no questions asked and no, not really any protocols that are really investigated by independent people.
Yeah, exactly. Yeah. So another question here, can any of the activation tips be reused? Hard times these days, so need to keep an eye on material costs.
Oh yeah, why not?
Yeah.
The activation tips, I mean the ultrasonic activation tips, you can reuse them.
Okay.
Just sterilize them and clean them, but usually they're pretty clean.
Can you mix liquid EDTA with hypochlorite? What's special about the EDTA tablet? So I think they've just
that's HEDP. It's not EDTA. It's a different chemical. So EDTA you cannot mix with you can, but you will lose the hypochlorite immediately. So
when you mix the EDTA with hypochlorite, it gets hot.
It depends a little bit on the types of irrigants you're using, but just when you use the pure chemicals in water and you mix them, just immediately hypochlorite is gone. Use the same with citric acid, you can make the tooth explode. No, but it really starts to bubble because it interacts like crazy. and not in a good way. It's not that, you know, it cleans better or disinfects better. This effervescence effect they used in the old days, they thought, you know, this is a good thing, but actually nothing really happens. You know, you need the hypochlorite ion in the solution, and the EDTA gets it out. So don't mix it. You can alternate. That's fine. Again, because the canal volume is so small, 3 microliters per canal on average. So you can alternate between EDTA and hypochlorite when you irrigate an instrument. But I would still preferably always have the hypochlorite in the canal when you instrument.
So basically, the big advantage of using the HEDP is that you have the advantages of a moleculator all the way through the treatment, and you're not affecting the antibacterial and the proteolytic effects of the hypochlorite.
Exactly. So instead of creating a heap of debris or dented mud, as Schilder used to say, and then digging it out from your isthmus again in the end, you keep it clean. Using the protocol that I just mentioned, you keep the canals clean. That's the main thing.
Yeah.
You know, keep them clean and don't introduce any problems that you don't want.
So Duncan has a question here. Why aren't the irrigation needles sonic as well? And that could save time with a simultaneous effect.
I don't know any Duncan. I'm just kidding. No, but hello from my rabbit to Duncan. No, yeah, I mean, there was kind of the Vibranch from it was, I think, from Holland. Vibranch. It looked a little bit like a sex toy. I'm sorry for my bad mind, but that was a syringe that had sonic effect. But you know, sonic effects really, even with the dedicated devices, are not that strong. So it's actually almost better. For instance, the way they propose it now with Dentsply, with the new endo activator, is really to introduce the solution and then activate it once it's in the canals, and then refresh it and keep instrumenting and activating and alternate between that. That also kind of keeps the debris low. So I think it's quite a good idea to have your sonic devices separate from your irrigation. Yeah. I think it's generally a good idea to, as I showed with the cleaning the pans, to have the irrigant in the canals and then do something to it. Can be laser, can be sonic, can be ultrasonic activation. Just spend your time that way with the patient or with the case, and it just will make your canals cleaner that way.
And then do you do 3 by 20 second activations as per?
I mean, I think really endo, it's really like cooking, okay, or like fly fishing, or like something. 20 seconds. I mean, come on, who spends 20 seconds activating an irrigant? Nobody, especially not the people who wrote the papers about it, you know. So it's nobody does that. You just do it because, you know, once you do ultrasonic activation, you need to also refresh a little bit the irrigant, and your assistant has to be trained to suction the right way. So because otherwise you lose all the irrigant relatively quickly. The same goes for laser activated irrigation. We use a pulsed hard tissue laser. So I think 20 seconds is too long. I mean, nobody does it for that. Then you just do it 10 seconds or something like that, then refresh it again, then again. And again, when I say refresh, you don't need 10 milliliters to refresh the irrigant in the canal. You need very little.
So how deep are you bringing your Irriflex? If let's say you've done a 25 or
working length, I bring it to working length. Yeah. Yeah. It's and it doesn't really over irrigate at all.
I think it's yeah. I mean, I use it.
Use a rubber stopper, and you use it too, right?
Yeah. I mean, it's you can't use a metal needle after you're used to using Irriflex.
You know what happened this morning? It happened to me. My assistant, the apprentice prepared the chair, and so I get my irrigation syringe, and I said, And I have this old, I don't even know what it's called anymore, this old kind of 30 gauge side vented needle that I used to use. And I just bent it at working length, but I could never actually reach working length in a curved canal. But I just kind of, you know, never really thought about it that much. But now I use it again. And I was like, oh, something is wrong. What is it? Oh, I have the wrong needle on, you know? And then it changed it back to the Irriflex, and it's the difference is really massive. And I also think the way your canal systems look, or way you when you work with a microscope, you really see how much dirt washes up through that. So this is, to me, fascinating.
Absolutely. So Vicky is asking, should we preheat our irrigants before we use them?
No, shouldn't do it. Because you make them unstable, and you could technically preheat the hypochlorite to make it a little bit more effective. We did some paper on that, but in the tooth, almost immediately, your irrigant will be 37 degrees because you have a lot of surface inside. It's 37 degrees, and the volume of the irrigant compared to the surface it touches is very low. So temperature inside the canal is what matters, and so you can use even a cooled irrigant canal. It will be 37 relatively quickly.
Yeah.
So I think it's an overrated concept.
Okay, right.
And actually the combination of the HEDP and the hypochlorite, you should never heat before or store it when you heat it, because then it starts reacting and your hypochlorite goes away. Okay. So you just use it at room temperature.
Use it at room temperature. And then basically it lasts for an hour, and it's all good for an hour.
Lasts for an hour, yeah, or 2 hours. And if you use 1% for 4 hours, but nobody in Britain uses 1%.
It's no, I think it's a whole. Some people don't use hypochlorite. I mean, I think we're trying to get a whole standard of people just using hypochlorite. I think it's really nice if they can have the chelating and the hypochlorite together in one syringe. And also there's less waste rather than having like 3 syringes with different materials in it or different fluids in it. It's nice just to have one syringe where you can have it all together.
Oh yeah, definitely.
Amazing. Thank you so much for your time tonight. And you're so generous to stay on so long after the lecture. The questions. I think
no worries.
You can from all the questions that we have that it's been amazingly well received. Thank you so much as well for leaving your email address. I think that's absolutely brilliant. I'm sure it'd be nice to have a look at some of those papers actually as well, and we can.
Oh yeah, just write me an email, or I send them.
Yeah, great. There's loads of messages coming in here. Thank you. I learned so much. Thank you a lot. Thank you. And it's yeah, I'm sure if we have any more questions that we can answer, we'll get in touch with you.
Okay, super.
I think
thank you for having me.
No, my pleasure, my absolute pleasure. We literally, dual rinse just arrived today, so it is available for anybody who wants to try it. If I would personally recommend to try both together, to try some of the dual rinse and Irriflex. I think it'll really change your whole irrigation, like just however you're doing it. If you're not using at least Irriflex, if you use both of them together, it's just going to make it really, really simple. I'll try and do some videos over the next week or two as well to show you how I'm using it, and it'd be great to get your feedback on that.
Super.
Brilliant. Thank you very much again.
Thank you, sir. Thank you. No disturbance.
No disturbance. I think, Matt, you scared.
I'm a little bit disappointed now, So
you are your own. It's I think that was great. Thank you.
Okay. Have a good one.
We'll see you soon.
Bye-bye.
If anyone has any questions, I can unmute everybody now that we've managed to get through that. So if anybody wants to ask anything, you can. Everyone good? Okay, great. We'll see you on the group, guys. Bye. Have a nice evening.